Thank you guys for the warm welcome. I greatly appreciate it. So today I've got a hard job ahead of me because I'm going to share my story about caring for my father after he was diagnosed with oral cancer. I chose to use my time today in this presidential address because I think there's some important lessons that I learned throughout my father's illness about the gap between our academic world and the experience of making medical decisions in the real world. If you are someone who has experienced the loss of a loved one recently, this might be a difficult talk for you. In fact, this is going to be a hard one for me to get through. So please feel free to cry with me. Hopefully we'll laugh a little bit. You could go sit by a friend, but step out if you need to. What I'm offering is that you make whatever choice is best for you today. So SMDM does a lot of work that has the potential to improve medical decision-making. However, there is a disconnect between our academic construction of an optimal medical decision-making process and the experience of making these choices in real time. So my talk today, I want to use this story to highlight that gap. And my second goal is to challenge us. I want to challenge us to do two things. Number one, to prioritize implementation. And number two, to develop new tools to support communications between providers and patients. Because ultimately, if our work doesn't serve patients or their families, then what is the point? On December 9th of 2016, my dad, Lee Sheldon Shaffer, was diagnosed with oral cancer after having an infection in his mouth that would not seem to heal. This is a photo of my dad taken 2 months before he was diagnosed with my babies, Lila and Grant. His diagnosis was a great surprise to our family and to his doctors because he didn't have any of the major risk factors associated with oral cancer. After the initial shock of the diagnosis wore off, I really considered my family to be lucky because I believed that we were uniquely positioned to deal with this cancer and make exceptionally well thought out choices about his treatment and about his care. I was so positive because this little girl grew up to be a decision psychologist who had spent, at the time, more than a decade exploring ways to improve how we communicate about health information. And in that capacity, I was well-versed in the literature on cancer care, on health communication, on risk perception, and broadly speaking, medical decision-making. In fact, at the time, I had already taught undergraduate and graduate courses on these topics, and I spent many hours debating the optimal method of health communication and decision-making for preference-sensitive decisions. So these are decisions for which there's no single dominant treatment. My dad himself was a social scientist and a retired college professor, and so he was someone who could easily understand the nuances about the clinical literature about his cancer. My mom rounds out our little trio. She had been a nurse for over 30 years, was an excellent source of medical knowledge, and would be the perfect post-treatment caretaker. When I was putting together this talk, I was looking for a professional photo of our family. And save my wedding, this is the only photo that exists. So please enjoy this photo from JCPenney's in 1983. So together, our little team, I thought we could tackle the decisions that faced us and swiftly determine the best care for my dad. I saw my role in this process as a decision counselor and as a patient advocate who would become an expert in the literature on oral cancer, who would present the treatment options to my parents, who would provide an assessment of the evidence associated with each of those options, who would lead my parents in a discussion of their values and their goals of care, and who would advocate for my father's preferences to his care team. So my first opportunity to use my experience was to help them choose their care team. Ultimately, my dad was going to be diagnosed with stage 4 oral cancer, and because of his advanced disease and need for extensive treatment, the cancer care team was going to include surgeons, radiation oncologists, medical oncologists, dietitians, speech therapists, dentists, wound care specialists, and social workers. One benefit of studying medical decision-making is that you know people in the cancer care field. So I reached out to my medical colleagues seeking recommendations of providers for his care team, particularly requesting physicians and practices who are known for their patient-centered care. This is one of 2 photos that my dad asked me to take of him during the treatment process. This is his absolutely favorite care provider. He was a technician who worked at one of the medical facilities, and he saw my dad on a daily basis, and he brought him great joy. So I wanted to honor him by putting him in the presentation today. So the standard treatment presented for my dad's stage and type of cancer was surgery, radiation, and chemotherapy. So he essentially had 3 big decisions to make. My father immediately agreed to the surgery because he was in a lot of pain, and he thought that the surgery was going to offer him the best chance for some time in the future where he could spend a little bit of time pain-free. So he went ahead with the surgery where he had a large section of his jaw removed, and the area was reconstructed with a bone graft and a skin graft from his leg. The surgery itself took 16 hours, had 2 teams of surgeons, one for the cancer removal and one for the reconstruction. The uncertainty for him began to arise when he wanted to consider, subsequently, the decisions about radiation and chemotherapy. He knew that these 2 treatments were going to be fairly brutal. And on top of that, we learned, after the final pathology reports came back from the surgery, that the cancer had already spread more than we believed initially. So where the first decision was easy for him to make, the second 2 were much harder. And this is where I thought I was going to shine. As the resident expert in medical decision-making, I thought, I know how to tackle this problem. And I roped my poor parents into a multi-attribute utility model exercise. So I gave them a full presentation of their treatment options, PowerPoint included, complete with information from the literature about dosing and length of courses of treatment, the side effects of the treatment, and recurrence rates. The short version of this exercise for you guys today is that the side effects were severe and could potentially alter his quality of life permanently. Even with the treatment, it was highly likely that the cancer was going to return. And the chances of survival, even with the treatment, were low. However, the chance of dying without the treatment was 100%. I also forced them into a makeshift values clarification exercise. I did all my best work. So we discussed what he wanted out of the rest of his life. He did not have a strong need to be physically active, but he loved intellectual activity. He wanted to be able to read books and write very long emails to his friends. He was an academic after all. And above all, he loved food. He loved to cook, and he loved to eat, and he loved to share meals with his people. We went to their house every Saturday for family dinner, and he wanted to be able to continue that tradition. This is a photo of Thanksgiving dinner, the year before he was diagnosed. And while Thanksgiving dinner in the US is traditionally a huge feast, our family dinners on Saturday were no less of a feast. There was always a giant main course, many side dishes, and a perfect visual presentation a la Emeril Lagasse. So my dad wanted to live, but there were limits to the conditions he wanted to live under. He was at peace with all that he'd accomplished in life, and he had no unfinished business. So he wrestled with his choice, and he talked it over with my mom for a few days. And he finally decided that he did not want to have chemotherapy or radiation. Yet that choice didn't end up being accepted by his care team. So although the oncologists on his team were chosen for their patient-centered nature, there was still great resistance to my father considering no further treatment. My dad talked with his first surgeon about his new thoughts on chemotherapy and radiation. The surgeon listened closely. He even congratulated us on a very academic exercise, thought it was important that he learned about all of the options ahead and the risks associated with them. But he said to my dad, in the end, I think you're going to choose the treatment because you're a reasonable guy. And it was in that moment that I knew that despite all he grappled with, our detailed discussion about what he wanted out of the remainder of his life, my most excellent multi-attribute utility model and values clarification exercises, despite all this work, I knew he was going to choose the treatment. Because what was left unsaid was that people who choose to forego treatment were not reasonable. The second surgeon went even further. They went to great lengths to discuss what they perceived to be a terrible path forward for an oral cancer patient who, quote, refused treatment. And in the end, more than anything, I think my dad wanted to be seen as a good patient. So these photos here are of my dad after he dutifully completed 6 weeks of chemotherapy and radiation. And so this is the first thing that our story taught me. It wasn't that I was unaware as a decision psychologist that the desire to be a good patient could influence decisions. Rather, until that moment, I didn't realize that the desire to be a good patient was so strong and such an all-encompassing norm. If there was anyone who was well-positioned to avoid this pitfall or to reject this norm, it was my dad. He was highly educated, he was articulate, he could clearly argue in favor of his values, and he had me. I was a very vocal pit bull of a patient advocate who would have moved mountains to have his will accomplished, and I had taken a leave of absence from work so that my full-time job could be getting him the care he wanted. But after those brief conversations with his doctors, he had completely changed his mind, and he was now resolutely set on having chemotherapy and radiation, just so no one would think he had given up. And the thing is, my dad, he isn't the only one who's had this experience. In fact, I think it's a pervasive part of dying in America. But before I lived through it, I didn't recognize its power. So our primary tools for this moment are patient decision aids, and later in the process, goals of care conversations. Our patient decision aids may make strong intellectual arguments that choosing to receive no curative treatment is a valid choice, particularly in situations like my dad, where the benefits of treatment are low. But these nods to a different path, to choosing comfort over cure, they occur in writing in a website or on a worksheet, and they're likely reviewed before we even visit the doctor. They can be quickly undercut by one offhanded comment from the care team. Patient decision aids are built with years of work by a team of researchers, but the power of a provider's words is unmatched. They weigh heavily on patients, and careless comments can have a lasting impact. Goals of care conversation are another tool we have at our disposal. These are structured discussions between providers and patients about values, preferences, and priorities regarding care. And they're helpful, but they often occur way too late in the course of treatment. The only physicians that are usually trained to have these conversations are palliative care specialists. And if you're talking to one of them, you've typically already come to the end of your curative options. While my dad was having treatment for 6 months, we missed a lot of important time with him. We got lucky because some of his treatment occurred in the city in which we lived, and some of his treatment occurred many, many hours away. We missed his 70th birthday, and so this is a photo of him with all the cards that we sent him to celebrate his birthday since we couldn't be there. I flew back and forth every 2 weeks, 10 days to 2 weeks to see my dad while he was not in my city. But my kids didn't get to see him at all the whole time. And so this is the welcome home sign that they made for him when he came back from chemotherapy and radiation. Now I want to stop and say, there are no villains in this story. There are no bad guys. None of these issues are the consequences of a healthcare team that is unprepared or uncaring. Rather, my father's care team was the opposite. They were kind, they were thoughtful, and they were patient. They were knowledgeable about the literature, and they were willing to discuss any article I found that I thought was relevant to my father's treatment. They wanted him to have treatment because they wanted him to live. So this is not an issue with physicians or a handful of physicians. Rather, I see this as a problem with the culture of cancer care, or possibly all care involving serious illness in the US. This is the second photo that my dad asked that I take of him during cancer treatment, and he would want you to see two things, so I must point them out. Number one, despite having the left half of his face reconstructed, he looked great. He wanted everybody to see that. The only thing that was slightly different was his smile. It was a little lopsided. It's kind of hard to reconnect all of those little facial nerves. And the second thing he would want you to see is his beard. He was very proud of this beard, and he was very proud and very curious about the science that allowed him to have a skin graft from his thigh put on his face and a full beard created. So my instructions were to take this photo, post it on Facebook, and make these 2 points for all of his friends to see. A second observation that I had during my experience was that not a single physician at multiple academic medical centers voluntarily provided information about my father's prognosis, neither to him nor to us. In each case, I explicitly asked, what do you think my father's chances are of survival with treatment? And each time, instead of providing an answer, they first asked my dad, is this information you want to know? And then they provided many disclaimers before proceeding with their answer. They wanted me to know that whatever their predictions were, they were likely to be wrong. A few indicated that they didn't have a crystal ball, and they were all clearly uncomfortable with the conversation. 2 physicians recounted stories where they told a patient that they had a very low probability of survival. The patient went on to live, and now the patient calls them on some anniversary every year to remind them that they're still alive. It's some version of the phone call that goes, I'm still alive, asshole, that I think every oncologist seems to have. As a decision psychologist, I'm familiar with a lot of literature devoted to the science of predicting probabilistic events. It is difficult to make predictions with pinpoint accuracy. But in many contexts, we can actually make predictions that are within an order of magnitude. I am also aware of a lot of literature devoted to the interpretation of single event probabilities. So the statistic, 10% likelihood of survival, of course, is based on an entire population, but it's difficult for an individual patient to understand its application to their decisions. And in fact, we spend much of our time here at SMDM discussing how to communicate probabilities of this type. And we work to identify best practices of communication that are incorporated into our health communication tools, like our patient decision aids. So given all the attention that the communication of probabilistic information receives in our science, I was, perhaps naively, surprised that the lessons from this research had not seeped into practice in these medical facilities. On June 5th, 2017, I came home after picking up my kids from camp during the first week of summer. This was 6 months after my dad had been diagnosed with cancer and 6 weeks after he finished chemotherapy and radiation. As soon as I stepped in the door, my phone rang, and it was my dad. He called because he thought he was having a heart attack. He sat down on his couch at home, and he had a sudden sharp pain that was radiating up his spine. And he was in a panic because he couldn't get a hold of my mom. For the first time in 6 months, after nursing my dad back to life, my mom went out to a book club meeting. So he got a hold of me. I called my mom. We drove to their house, and we quickly took my dad to the emergency room. They ran several tests, and they did a bunch of imaging, and then all was quiet for a while. An hour or so later, the physician returned. And he quietly informed us that there was a large mass on my dad's spine. The mass had caused my dad's spine to fracture, which was the cause of his intense pain. Confusion spread among the 3 of us as we tried to wrestle with the implications of what he had just said. We were confused because we thought, aren't we here to talk about a heart attack? So we tried to figure out what he was not explicitly telling us. Slowly, I realized that the cancer returned just weeks after he had finished treatment, and maybe it never left at all. Like a little kid, I asked the doctor if my dad was going to die, and he didn't answer. He just hugged me and left the room. After my father's cancer returned, the question again returned to prognosis. I asked each of the physicians who came in, How long does he have to live? Again, they were reluctant to provide me with their best guess. They wanted me to be aware that their predictions were destined to be inaccurate, but I nudged them forward, indicating that I was really just more interested in the order of magnitude. Do you think he has days? Do you think he has weeks? Months, maybe a year? From a practical perspective, this was really important for care planning. But again, I got the distinct impression from their discomfort that these were not conversations that they frequently had with patients and their families. And this puzzled me deeply. I could not fathom how people were able to make decisions without this critical information. For example, I could take a 12-week paid leave of absence from work, but the timing would be critical. I was only eligible for this benefit every few years, so if I took leave too soon, I wouldn't be able to take time off again later in the year or the following year. I was also puzzled because there is a large academic literature on prognosis at the end of life and several prediction models that have impressive levels of accuracy, some even built by SMDM researchers. So the information that I was looking for is knowable. Yet this work is not making its way into practice. My dad died exactly 2 months later. Palliative care was a blessing, and his final weeks at home were more peaceful and more comfortable than any of the prior 8 months. This photo might be difficult for some of you to look at, but it's actually a very positive memory for me. My dad was in his home. This was taken 2 days before he died. And we have a folding chair to the left of the photo that my mom is sitting in. And it had a rotating cast of characters. Sometimes it was me, sometimes it was my husband, sometimes it was our kids, sometimes it was their friends. And there's a little table to his head on the left that played music, his favorite kind, the whole time, all day, every day. And his cats, they took turns curling up at his feet. Palliative care was such a paradigm shift from cancer care that only in the presence of this different perspective did I start to recognize some of the flaws in our system. As a researcher who studies medical decision-making, I thought, from the perspective of our literature, that we had revolutionized patient decision-making. We had tools like patient decision aids and life expectancy prediction models. But as a daughter who was caring for her father in the trenches of his cancer treatment, I realized that our tools are not making the impact that we want. We're making great strides in some areas of our science, but those improvements are staying locked in our academic journals. Now, I'm certainly not the first person to notice that implementation is difficult and that many good interventions do not stick. But my experience opened my eyes to just how far off the mark we really are. It's not just that our interventions are not being used in practice. Rather, even if they were perfectly implemented, they're not likely to have the impact that we hope. Even if patient decision aids existed for every single cancer care decision, and even if they included a thesis about how foregoing curative treatments is a valid choice, there would be many people like my dad that would still choose aggressive treatments towards the end of their life, despite our efforts to center patients' values in their decisions. And they would do this because they consider themselves to be a reasonable guy and a good patient. And even if every physician was equipped with access to the best prognosis prediction models for every patient, the technology will be useless without a culture in medicine of having difficult discussions about life-limiting illnesses. It's information that patients often avoid knowing despite its discernible value in their treatment decisions. And this problem is not a one-way street. It's not just physicians not sharing with patients, it's patients not wanting to hear this information either. So instead of more decision aids on this topic or more prediction models, we need different interventions. We need ones that address the psychological avoidance. We need ones that support patients in the difficult process of coming to terms with their own mortality. In the US, we largely do not talk about death. We also need to train practitioners throughout all professional schools and in all training programs in the art of communication about single event probabilities and how to explain their utility in health contexts. And these conversations need to happen in thoughtful, deliberate ways, and not in off-the-cuff estimations or in passing comments. And above all, they need to happen much earlier in the course of treatment. One of the themes in my work over the last 20 years has been the development of an evidence-based approach to using narratives or stories in patient communication. My purpose in telling the story of my father's diagnosis, treatment, and death today is that I hope it will illustrate what stories can do. And that is that they can provide the texture of a lived experience. In this case, my lived experience is that there is not just a gap, but a full-on gulf between the work that we do in this society and its impact on real-world decision-making. Even when people have the advantages that my family did. My dad was a fully insured college professor patient whose life partner spent their career as a nurse and whose child was an expert in medical decision-making. Even in this best-case scenario, decisions were not truly patient-centered. And we struggled to get the information that we desperately needed to make choices. And I had never felt so helpless despite actually having knowledge and skills that could be useful. So the first thing that I want to say to you today is thank you. Thank you for listening to my story. The second thing I want to say is that we still have a lot of work to do. We, as a society, we need to own that medical decision-making isn't as clean as we think it is. And we haven't come as far as we like to think we have. Yes, we have made strides, but there are a lot of places where things haven't changed. At the same time, I do remain optimistic. This task is hard, but I am confident that I'm talking to you guys who are the right people for this problem. Thank you.